بسم الله الرحمن الرحيم. السلام عليكم. طبعا في البدايه بحب اشكر اخي وصديقي العزيز الدكتور سيد عبد الحميد، واخي وصديقي العزيز الدكتور حمد تمام، وكل اعضاء قسم جراحه العظام بهنا على الدعوه الكريمه والمشاركه في المؤتمر ده. يعني طبعا يعني السيتويشن اللي انا فيه صعب جدا اتكلم عن تيومرز بعد دكتور وليد عبيد، وبعدين الموضوع فيري كلاسيك، لكن هو الفكره الحقيقه معظمنا عارف التفاصيل، لكن احنا هنحاول تو هايلايت سام بوينتس هي المهمه اللي نحاول نركز عليها في المحاضره دي او في التوك دي. زي ما احنا عارفين الجانسل تيومر fairly common. It affects usually adults. However, some cases rarely affect adolescent, especially female. So do not exclude giant tumors in immature patients exclusively. There are slightly female predominance. Affected epiphyseal, eccentric, most affected site is the distal femur, followed by proximal tibia, distal radius and sacrum, and others. Sometimes affects the pelvis. We know all this. The presentation is usually painful swelling in most cases, sometimes pathological fractures, sometimes presented by joint effusion if it's very near to the joint. Tumor, usually lytic lesion with not well-defined lesion. The bones, usually it is an expansile lesion. Usually there is no sclerosis. Typically, there is no sclerosis. Sometimes the bone is deformed, and sometimes cork and penetrations occur with soft tissue extension. The classic classification is in Campanacci. This is the most famous one. There are many classifications, but this one is a very old one and still valid and still validly used for the treatment. It classifies the types according to the X-ray appearance into latent type, 15%, active lesions, 70% most of the cases, and aggressive lesion, which represent about 15% of cases. MRI is mostly used to define the soft tissue extension of the tumor and also the interosseous extension of the tumor. CT sometimes used, sometimes not. The gross pathology, we know the grayish brown with some areas of hemorrhage, and the histopathology, as Dr. Walid already mentioned, a multinucleated giant cells, many nuclei up to 400 sometimes. So what is the goal of treatment? Remove the tumor and then reconstruct the defect. How to remove the tumor? Which is called the extended curettage, and we'll talk a little bit about that. We do not do simple curettage. It is extended curettage. This is a very important point, and this is one of the highlighted points that I want to highlight. Restore the function after that. Because in the restore function after that, either using allograft, autograft, arthrodesis, or arthroplasty, according to the situation, to the location of the tumor, and also the size and the degree of destruction. Recurrence. This is a locally aggressive tumor with high incidence of recurrence, especially in simple curettage. The incidence of recurrence is about 50% in simple curettage. So do not do simple curettage. Never. Extended curettage has a recurrence rate of less than 10%, so this is the standard treatment, the extended curettage. Lung metastasis is very rare, sometimes occur, but it's almost always associated with the case of multiple recurrence. So how to do extended curettage? First of all, the window that we open to curate this tumor, the size of this window is very important. It should be at least as large as the tumor itself, unless bigger. This is very important to remove the whole tumor mass from the defect. You should open a very wide window, as large as the tumor, to avoid what's called the around the corner residual parts of the tumor. Also, after doing curettage with the curettes, you should use a high-speed burr. This is the extended curettage. This is it should be applied in all cases. And after that, we should use some sort of cautery, we use some sort of techniques to avoid recurrence. The most famous of which is the phenol, electrocautery, argon beam coagulator, which is not very available. Liquid nitrogen is very good, however, it has some disadvantage. It's have a post-operative fracture incidence, wound healing problems, nerve injury, technically demanding a little bit, and it's not available everywhere. Follow-up, the patient is followed up for pain, swelling. In every follow-up, we examine the patient clinically. If we have any pain and swelling, we should do X-ray, and if there is any recurrence, we should do CT chest. Duration of the follow-up, the first year every 3 months post-op, second year every 6 months, and then every year afterwards. So we have giant cell tumor. To summarize the algorithm of treatment for grade 1, 2, and 3, without marked destruction, we use mostly extended curettage and cement or bone graft. For the grade 3 with a marked destruction, we should use in-block excision and reconstruction. For the reconstruction of the distal radius specifically, this is the topic of our talk, we either use autograft, allograft, cement spacer, or vascularized or non-vascularized fibular or other graft. The fibula is most commonly used. In reconstruction, we either preserve the radiocarpal and DRUJ whenever possible. If we cannot, we may preserve only the RUG. If we cannot, we may use one bone for arm. In this case, we do not preserve the RC or the RUJ. And this is the case, one of the case presentations that I will present here. This is a 23-year-old lady. She was a medical student in the 5th grade. She presented with recurrent giant cell tumor after 1 year of the surgery. And this is X-ray and this is MRI. For which I decided to redo extended curettage and then used the phenol to avoid recurrence. I decided to do the 2-stage. I did not do a bone graft immediately in the same surgery to ensure that I don't have recurrence. Because she's a medical student, I don't want to expose her to another grafting and then failed and then lost the area of the graft. And post-operatively, I used the denosumab to avoid recurrence also, to enhance, decrease the incidence of recurrence. And later on, after about 3 months, I did bone grafting, iliac bone graft. And this is 6 months post-op X-ray showing good healing, no recurrence. As the patient is okay. The patient disappeared for 6 months, and then she came back with a painful swelling. And this is the X-ray and MRI, another recurrence. So recurrence and recurrence. And in this case, I decided to do in-block resection. I removed, and I do 2-stage, remove the tumor in block, and then I put a cement spacer to use the reactive membrane technique. And later on, 6 months later, I removed the cement and put a non-vascular fibular graft. And this is the final X-ray. It's about 1 year ago. I called the patient, and I asked her for this video. She has an excellent functional results. And I asked her for a plain X-ray. However, she told me she got married 1 month ago, and she's pregnant, and she cannot do a plain X-ray. So we have a happy ending. At this point, I realized how much my surgery was successful. Thank you very much.
This is happy ending session. كل العينين بيتجوزوا في الآخر. And now we'll shift a little bit outside the field with Dr. Ahmed Abdelrazzak. He will talk to us about neglected fractured distal femur in a child. وكبر واتجوز برضه.
السلام عليكم. في البداية بحب أشكر دكتور سيد عبد الحميد والدكتور حمدي تمام على الدعوة الكريمة. يعني هنخفف الوطأة شوية وهنلتقط الأنفاس وناخد حالة خفيفة كده. It's a neglected distal femur fracture in a child. For introduction, fracture femur usually classified according to the location as subtrochanteric shaft proximal, middle, and distal third, supracondylar and distal femoral physeal fractures. Fractures occur most frequently in middle third. According to Hinton et al., the annual rate of femoral fractures in children is 20 per 100,000. With regard to the age, the distribution was bimodal, with peak at 2 and 17 years. Boys had higher rates of fractures than girls in all ages. Our case presentation is a male child, about 5 years, with a history of falling from the 3rd floor. There was a head trauma and fractured distal femur. The patient was comatose and admitted to the ICU in another place for about 1 month until general condition is improved and he became fully conscious. This is the early X-rays with the fractured distal femur, severe shortening and overlap. And he, unfortunately, treated in this period of ICU admission by simple slab, which leads to malunion of the distal femur in a varus and overlapped shortened position. And this is the shortening. The patient presented to us by limb length discrepancy, shortening about 7 centimeters, malunion, soft tissue contracture, and muscle weakness. This is the clinical photos and the preoperative X-ray with excessive colors regarding this period. By reviewing the literatures, many papers talk about the fracture healing by excessive colors in patients with head trauma admitted to ICU. Our aim and method of treatment is to do reduction of the fracture without traction on the neurovascular bundle by shortening the proximal fragment and correction of the malunion and correction of the limb length discrepancy by gradual lengthening by using a simple Elizarov frame composed of 2 arches and 6 shunt screws. This is our plan to disrupt the callus, to do traction to correct as much as we can, then excise the distal part of the femoral shaft to do anatomical reduction and applying the frame. This is how the frame looks. Simple frame by 2 arches and 6 shunt screws. This is immediate post-operative with good reduction and application of the frame, which we shall use for lengthening. We start the gradual lengthening until the limb length equality was reached. And we instruct the patient to continue regular follow-up and keep the frame until complete consolidation. Unfortunately, they were divorced على عكس الحالات اللي فاتت. هنا the parents divorced and the child didn't continue the follow-up.
يعني تيومرز احسن من الديفورميتي.
بالظبط. تيومرز بتجمع الديفورميتي ويتفرق. The frame removed early in another place, and after about 8 months, the child came up to us by this presentation. Increased anterior bowing of the femur and wide limbing due to early removal of the frame before complete consolidation of the regenerate. We try to convince the mother to leave him for remodeling to be corrected gradually, but she insists to do correction and accused by the father that she is the cause of the deformity. And we decided to correct the deformity by doing osteotomy and intramedullary nails. Translation inevitably occurred, and this is the early union by correction of the deformity and the limb length. This is complete union after 3 months. And this is the gait of the patient before removal of the Nancy nails. The prominence of the Nancy nails is obvious. And after complete union, after 6 months, we remove the nails. And the patient walks nicely. And we hope they return again. Take home message, fracture healing in children is so fast. In patients with head trauma, excessive callus formation occurs. Provisional reduction is so important if surgical intervention had to be postponed. In neglected cases, if acute anatomical reduction is dangerous, acute shortening and gradual lengthening is a good solution, and Elizarov is an excellent tool in these cases. Thank you.